Hello everybody, I'm Anna, I'm a PhD student from the University of Hamburg, and I'm going to present the findings of my PhD project about improving quality of care by increasing adherence to treatment. Although adherence is a very important driver for treatment success, the WHO estimated adherence rates for or amongst chronically ill of only about 50%. There are many different approaches how to increase adherence, but in this PhD project I focus on the simplification in the pharmacological therapy amongst diabetes patients, who are for sure a relevant subgroup, giving the actually both increasing health and financial burden of diabetes worldwide, and their low reported adherence, which again harms the treatment success and may translate into further costs. Type 2 diabetes is managed through a stepwise therapy that usually consists of lifestyle modifications in the beginning and then a sequential addition of oral medication and potentially insulin. And in this context, we are analyzing the effect of so-called fixed dose combinations. That means pills that include many active substances, 2 or more, in only one pill, compared to having to take the pills separately. So our hypothesis is that these fixed dose combinations reduce the pill burden and may therefore affect medication adherence. And the key question is the effect of fixed dose versus loose dose combinations on medication adherence. To do so, we use data from the Techniker Krankenkasse, which is the largest German sickness fund. And in this administrative data, we can measure adherence as the proportion of days covered with medication. That means based on their refill pattern, assuming that a refill indicates that the medication was actually taken. And in addition to adherence, the data set allows us to analyze many other interesting secondary outcomes. We are conducting a two-step risk adjustment combining entropy balancing and a difference in difference estimation, to first increase the comparability between the study subjects, the study groups, and then really isolate the effect of fixed dose combinations. And to do so, we basically identify a pool of insured whose blood sugar is not sufficiently controlled by just one substance anymore, and they need to take a second substance, which was either prescribed as a fixed dose combination, that means just in one pill, or as 2 separate pills as a loose dose combination. And this very nicely allows a before-after comparison and a between-group comparison to really isolate the effect of fixed dose combinations. Okay, now let's look at the results and what they may imply. So we observed that adherence was significantly higher amongst patients who switched to a fixed dose combination compared to patients who switched to a loose dose combination. And the effect was largest in the third year, growing from a 24% difference in adherence to a 30% difference in adherence. The finding is in accordance with earlier findings from the US, but in fact the effect is a bit stronger. Reasons could, for example, be differences in the study design, or maybe also differences in the healthcare systems, for example, with respect to reimbursement policies of drugs. In addition to this, persistence was measured as the time until discontinuation of treatment. And it was also significantly higher in the fixed dose combination group. We can see this very nicely by looking at the so-called Kaplan-Meier curve. And on the x-axis, we can see the 3 years of our study period expressed in days. And on the y-axis, the survival expresses the percentage of patients who are still continuing treatment, because we could not observe a gap in the medication refills for them. And the curve is falling much steeper for the loose dose combination group, which is the dotted line here. And most of these patients have really interrupted their therapy at some point after 3 years. So this graph also is in favor of the fixed dose combination. We also inspected interesting secondary outcomes. First, we could not find any significant differences in the proportion of patients with adverse drug events in both groups, and in the number of emergency visits. And these two variables may reflect the therapeutic safety to some degree. Furthermore, we couldn't find any differences with respect to the outpatient cases, and we couldn't find any differences of disease-specific morbidities, at least not in the 3 years that we are observing. It's possible that these happen a bit delayed. But 3 years is already quite a long study period. The findings are particularly interesting if you think about that fixed-dose combinations do not allow for an individual or patient-specific dosing. And also in the case of a side effect, it's actually quite difficult to identify which substance was responsible for this effect, because you cannot just play with the separate pills and with the dosing. So I thought these findings are very interesting. And something that's a bit intuitive, we found a significantly lower number of pharmaceutical prescriptions in the fixed-dose combination cohort, and this is strongly driven by the anti-diabetic prescriptions because you have a 2-in-1 pill. We also did 3 subgroup analyses. First, we looked at patients with an already high adherence in the pre-period, when they have just received one substance. And again, our results are in favor of the fixed-dose combinations. However, the effect was smaller compared to the full sample. And this shows that the reduction in pill burden may be particularly relevant for those who have shown difficulty with staying adherent. Second, we looked at patients with polypharmacy. So that means patients who are taking multiple medication, here more than 5 medication. And compared to the full sample, we find a larger effect in favor of fixed-dose combinations, at least in years 2 and 3. And that could simply mean that if you already have a complex medication regimen, the fixed-dose combinations can support you particularly. In addition to this, and that's also intuitive, we could not find significant differences in the number of prescriptions anymore, and we assume this is because everybody is already receiving a lot of medication. Lastly, we excluded patients with other severe diseases such as cancer or psychological disorders, and we saw a bigger effect as well in favor of fixed-dose combinations. And this could indicate that patients with additional diseases, and especially with additional severe diseases, are focusing on the treatment of the more severe diseases, so that the diabetes is maybe not of priority for them. And therefore the effect is larger if we only look at patients without severe other diseases. Okay, now let's draw some conclusions. Fixed-dose combination products may provide an important treatment option amongst type 2 diabetes patients to increase adherence, and in particular amongst patients with a more complex healthcare demand and patients who have demonstrated already poor adherence in advance. Therapeutic safety or healthcare utilization was not compromised in our study, and we could not find any differences with respect to disease-specific morbidities. I think that the approach of prescribing a fixed-dose combination may be rather simple compared to other strategies aiming for increased adherence, like, for example, writing a diary or targeting communication between the doctor and the patient. However, amongst other limitations, you have to keep in mind that this study does not yet take into account any economic implications. Okay, this was my last slide. Thank you very much for your interest.